And hi, everybody. So I recognize some people here, right? I'm happy to make this a more interactive session, so just stop me along the way, ask questions. It makes it a lot more fun so I don't just drone on, which I'm famous for doing. So we're going to talk about thymectomy today and what it is, and should I have it? And this is the other thing I do is to paint. So here's the thymus. I didn't paint this. So the thymus gland is this gland right here that sits in between the two lungs and over the heart. And this gland is a gland that's big when we're born and shrinks up as we get over the age of 20. In people with myasthenia gravis, sometimes this gland will get big again after it's shrunk. And sometimes it will turn into a little cancer called a thymoma. That cancer is not a cancer that spreads all over the body, but it's a local cancer that tends to just grow very, very slowly. So it's not as bad as a lung cancer or a breast cancer or other kinds of cancers. But it does happen in people with myasthenia. So what does the thymus gland do? So the thymus gland, it gives instructions to the immune system. So some of the immune cells grow in that gland, and they then go out all over the body. And so that's what the thymus does. So here's a little bit of some wonky details about the thymus. So here's the thymus gland right here, and it makes some of these cells that then go into the bone marrow. And as you heard Dr. Bird, some of you may have heard Dr. Bird say how you can destroy the immune system in people with very, very severe myasthenia and then reconstitute it. Well, this is what you're doing. You're taking the bone marrow, basically, which is where the thymus where some of these immune cells are, and then you get rid of them, and then you put new ones in, essentially, and reboot the system. So what happens to me when they take your thymus out? Nothing. So when the thymus is a little bit like the spleen, when people you may have heard that people get in a car accident, they have the spleen ruptures, they take it out. You may be a little bit more prone to infection when the spleen comes out, but when you take the thymus out, we don't realize that anything happens to people. So it's not a big deal to take that gland out. It's not like you're taking out some vital organ that you depend on. You don't get any more infections or anything like that when you take your thymus out. Okay. So let's just talk a little bit about myasthenia gravis and the different kinds of myasthenia, and do you take the thymus out in all kinds of myasthenia or not? And so there is myasthenia like in the blue here, that's just ocular myasthenia, so it just affects the eyes. And ocular myasthenia is myasthenia that doesn't spread to involve other muscles of the body. People who have ocular disease will stay just ocular if they don't generalize in the first 2 years after the onset of symptoms. So if you just have eye symptoms, double vision, droopy eyelids that come and go, that's ocular myasthenia. And if you have those symptoms in the first 2 years, then it doesn't, and the disease hasn't spread to other muscles, then it's not going to spread to other muscles after that. So it will remain purely ocular. And so the question is, so that's one kind of myasthenia. There's what we call early onset myasthenia. So people younger than the age of 40 or 50. As you get older, your definition of older changes, right? So 50 is the cutoff now for early onset disease. So myasthenia is categorized as people who get it when they're younger than 50 and people who get it when they're older than 50. There are some differences in the disease, but that's why it's categorized like that. But for purposes of myasthenia, For thymectomy, we don't really worry about it too much, except for an instance that I'm going to tell you about in a minute. And so most myasthenia, as you can see, it comes on later than 50, although in young women, it tends to come on before the age of 50. So women tend to get it before the age of 50. Very often, men tend to get it after the age of 50. So it's a disease of younger men and younger women and older men. There is myasthenia that has associated with thymoma. So that's the thymoma myasthenia that I was talking about earlier. And sometimes people who have a thymoma, which is often found by mistake. So, you know, somebody's in a car accident, you get a chest x-ray, and somebody sees a big mass on the chest x-ray, and my gosh, you have a thymoma. Well, it's really important that your surgeon, because you got to take the thymoma out, you go to a surgeon, that the surgeon realizes that, hey, you know, you could have myasthenia with it. So at our place, anybody who comes in with a thymoma is often sent to me to be evaluated for the possibility of myasthenia. The reason is you don't want to have surgery, you don't have your thymus taken out unless your myasthenia is really well treated and optimally treated. If you wait to diagnose the myasthenia in somebody with a thymoma after the operation, you may have trouble after the surgery. So anytime anybody is going to have an operation of any kind, not really just a thymectomy, so long as the operation is not an emergency operation like an appendix that's about to rupture or something, you really should have the surgery when the myasthenia is really optimally treated, really well treated. And so we always tell the surgeons that if you have a thymoma, if you have a patient with a thymoma, make sure you send them to the neurologist first to make sure that number one, do they have myasthenia? Because not everybody with a thymoma has myasthenia. And number two, that it's really well treated before you take them to the operating room. And then there's MuSK myasthenia. And so MuSK is an antibody. So it's an antibody against this protein called MuSK. That kind of myasthenia tends to happen in younger women. And those patients tend not to need thymectomy. So we don't typically do thymectomy in MuSK patients unless they have really severe disease that's very hard to control with medications. So while thymectomy, as I'm going to tell you in a minute, is a really good treatment for people with myasthenia, it's not so good for most people with MuSK myasthenia. And then there's a new kind of myasthenia that was recently described called LRP4. So LRP4 is another antibody like MuSK that happens in people who have the myasthenic symptoms. And those patients should probably get thymectomy. And then there's a seronegative patient. So patients, who have myasthenia gravis, they have the double vision, the droopy eyelids, and so forth. You need to have that diagnosis confirmed with a test, some kind of a test, whether it's an antibody test or an EMG test, to make sure that what you're dealing with really is myasthenia and not something else that gives you double vision and weakness. So there is a group of people who have droopy eyelids and double vision and trouble swallowing and trouble speaking. So they look like everybody else with myasthenia gravis, but their antibodies are negative. So they are called seronegative patients. That's about 20% of people, if you take all people with myasthenia gravis. But in somebody who has seronegative disease, what you want to do is make sure that they have myasthenia by looking at either a single fiber EMG or repetitive nerve stimulation or some other way to confirm that they really have the disease, so that you know that you're treating these patients. So all of those patients that I mentioned will benefit from thymectomy, as I'm going to show you. Now you got to remember that myasthenia gravis is also associated with other autoimmune diseases. This probably slide is way too small for you to see. But anyway, so a lot of times people with myasthenia will get lupus, or will have thyroid disease. Those are common ones. They may get skin rashes and other kinds of things, as somebody was just mentioning. So there are other autoimmune disorders that coexist with myasthenia gravis, and your doctor needs to sort of be aware of those and keep thinking about them all the time. So why should we do a thymectomy? Well, the thymectomy is really part of the treatment of myasthenia gravis for most patients. And we're going to talk about who benefits from this in a minute. And what you're doing is trying to improve the symptoms of myasthenia gravis. So just the daily symptoms that people battle with all the time. That's what thymectomy is designed for. It's designed to reduce the amount of medications that you take, especially the prednisone or IVIG or plasma exchange or whatever you're on. So we're trying to keep the doses of these things as small as possible. We're going to try to reduce exacerbations. So some of you know that every now and again, for either reasons of infection or just because the bad humors in the air cause the myasthenia to get just out of control. And so that's called an exacerbation. And people who have thymectomy have reduced numbers of exacerbations throughout their course. So who should get a thymectomy? So everybody with a thymoma needs to get a thymectomy. If you have a thymoma, that needs to come out. There's no other good treatment for thymoma. There's additional treatment, which is usually what's called adjunct or adjuvant treatment, in that people with thymoma, if it's spread too far in the chest wall, they need to get radiation or they need to get chemotherapy sometimes. But otherwise, surgery is really the first line therapy for thymoma. So when MG begins younger than age 50, almost all patients should get almost all patients with generalized disease should get a thymectomy. So if you're younger than 50, it's really kind of a no-brainer. You should get a thymectomy. So when is the best time to have a thymectomy? Remember, a thymectomy is not an emergency, okay? The emergency therapies are prednisone, IVIG, plasma exchange, maybe Soliris, but thymectomy is not one of them. Thymectomy is for the long term. It's not for the short term. So if you're having trouble breathing, if you're having trouble swallowing, that's not the time to get a thymectomy. You gotta get it when, like I said before, like any other operation, when you're really stable and strong. So when you're stable, when you're not short of breath, when the disease has been present for a couple of months. So because it can be a little rocky in the beginning once the symptoms start, and sometimes the symptoms flare up for no apparent reason. So you don't want to be having a thymectomy then. You want to wait. You want to wait a little bit until the therapies have kicked in a little bit and stabilized things. And then if you're on prednisone or other steroids, you got to be on the lowest dose possible to get thymectomy. Why? Because, anybody know why? Why?
There was a study that found the lower the dose, the higher the dose you're on before the thymectomy meant the higher the dose you needed.
So the higher the dose you're on before the thymectomy, the higher the dose you're on. I'm not sure, I don't know that study, but it may well be the case. But one of the problems with prednisone is it's the wound healing. So doses of higher than 30 milligrams a day, your wounds don't heal so well. And you might even notice that if you're taking that kind of dose of prednisone, that your skin kind of gets very fragile and rips easily, and it doesn't heal so well. So what we like to do is to treat people and get their steroid dose as low as possible, around 10 milligrams or so a day, if possible. Now sometimes that's not always possible, but we try. That's what we try to do. And remember, thymectomy is not an emergency, so don't insist on it to your doctor if this is something that you're talking about. So it's kind of iffy to give thymectomy for purely ocular disease. So if you've had just ocular myasthenia for 10 or 20 years and you're 60 or 70 years old, probably getting a thymectomy is not going to help, and it may be a little dangerous thing to do. So it's not entirely clear that that's somebody. I will do it in patients who are younger. We just did it in a young guy who's 33 and has had myasthenia for a few months. And so we did a thymectomy in him because we could get him on a small dose of prednisone and get him strong for the surgery. The studies that were done have been in people younger than the age of 65. Now, that doesn't mean if you're 66 or 67, you can't have a thymectomy. It's still something to think about. But the studies have been in patients younger than 65. And I think like everything else in medicine, you have to individualize it to the patient. You know, somebody who's 67 or 68 is in great shape and has no other medical problems and doesn't have heart disease or whatever, you know, you can do a thymectomy in that patient. It's not a complete contraindication. But it's not something that we get too excited about. If you're 80 years old and you have myasthenia, I'm not sure I would do it in that person. So, when should you not have a thymectomy? Thymectomy, kind of like sex, it's not an emergency, right? You got to just make sure that you do it at the right time. And if the myasthenia is unstable or it's very active, don't do it then. And if you've had eye symptoms for more than a couple of years, yeah, probably I wouldn't do it necessarily unless you're younger than 50. And yes?
What do you mean by symptoms are active? Do you mean fatigue and...
No, so fatigue is a common symptom in myasthenia. I mean weakness, and I mean shortness of breath primarily. If you're really kind of short of breath, and it's from myasthenia, it's not from heart failure or something else, I think that I wouldn't do a thymectomy. The reason is, you go on a ventilator, so you go on a breathing machine when you're in the operating room. You come out of the operating room on a breathing machine for a very short period of time. But if you're very weak in your chest muscles and you can't breathe very well, then you're not going to be able to get off the breathing machine. And I've seen patients gotten transferred into a Presbyterian where they've had failure to wean from the ventilator after a thymectomy or after other surgeries, and it's because their myasthenia has been too active. So that's what I mean by getting the patient really strong before doing an operation like that. And mainly it's to getting off the ventilator. It's the main problem we have with that. And then MuSK myasthenia, again, it's not clear that thymectomy helps people with MuSK. So this is kind of the operation. I'm not going to show you any gory pictures, so I don't want to freak anybody out. But you can go on YouTube and you can see all kinds of ways that thymectomy is done. It's done by robot now, primarily. So it's not like, in the old days we used to crack the chest open, take the thymus out, and some surgeons will still do it that way up in New York and other places, and they say, well, but this way you get all the thymic tissue out. Now, it's a little bit controversial, but I think most people will do it with a robot now. So the robot is kind of like PlayStation. The surgeon sits in the corner of the room and they kind of play like this, and then the robot. I might have a little something to show you here. And they make just a few incisions, so it's not a big incision. So they make a few. They poke a couple of different holes in the chest wall. So they put the robot arms in there, and then the robot, they manipulate the robot from outside. So nobody's really putting their hands in your chest anymore. And actually, it's almost like an outpatient procedure. They take the thymus out and you go home the next day. It's kind of crazy. In fact, the fellow that we just did, I saw him in the recovery room to say hello. He was awake and talking and everything. And then I went back the next day to see him on the floor, and they said, oh, he was already discharged. So I was like, okay, this is great. In the old days, it used to be, 10 days in the ICU, you had to have a chest tube put in, and it was a whole rigmarole. So now it's really a fairly, while I never want to say surgery is an easy surgery, like no, surgery is not an easy thing, it's become much easier than before. The recovery time, like if you want to go back to work or if you want to go back to doing whatever it is, probably around 8 to 12 weeks. Now the surgeons usually say 6 weeks. Now surgeons, for every surgery that I've ever heard of, they always say, yeah, you got 6 weeks to recover. No, I don't think that's really the case. I think it really does take longer. And it probably takes a good 12 weeks before you're really completely healed from the operation. But when people heal from it, it's wonderful because they don't have big scars, they don't have big problems from it. And if you do it at a place where they do a lot of these, then they don't cut, your phrenic nerve by mistake or whatever, which can be a problem, and it can paralyze the diaphragm. So it's not completely risk-free, obviously, because you got people putting stuff in your chest. So it's not, but in good hands, it's really well done, and it's done fairly routinely, and the discharge is fairly fast. So that's kind of all I had